Welcome all to the video of Easy ECG. In this video, we are not discussing anything about the theoretical portion, that where the leads are placed, why the leads are positive, why the leads are negative. That's nothing. We just here discuss how you can clinically diagnose ECG in just 1 to 2 minutes. So let's start. So in the ECG, you have to tell first about the rate. In the rate, you will see in the rhythm strip. Okay. In the rhythm strip is lead 2. Here also lead 2, but here a different lead for the rhythm, rate and rhythm measurement. This is called the rhythm strip. Okay. In the rhythm strip, we calculate the rate and we see the rhythm. How to calculate the rate? You take the QRX complex, top of the QRX complex, okay, and count the small box. Here the 23 small box are present, okay. So the formula is 1500 by small box. Okay, so 1500 by 23 means 65 almost. Okay, so 65 beats per minute is the rate. Next, you have to see the rhythm. To see the rhythm, you have to see 3 consecutive middle portion of the QRX complex. Okay, you can see here this is 23 small box. 23 small box means the rhythm is regular. Okay, so rhythm is regular. So here a question comes, how to calculate the rate of a irregular rhythm. So let's see this ECG. Here the rhythm strip, and you can clearly see that here the 8 small box, here the 10 small box, here the 12 small box, then almost 15 small box. So the rhythm is not normal. So now how to calculate rate in this ECG? You have to count the 30 large boxes. Okay, so you can count here 1. So here it is the 30th big box. Here it is 1. Okay, so in this 1 to 13 big box, you have to count how many QRS complex are present. Count from here 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, and 15. So you can see here the QRX complex is 15. Next, simply multiplied by 10 means 150. So the heart rate in this irregular ECG is 150 beats per minute. So it is obviously tachycardia. It is the trick that for the irregular rhythm, QRX complex in the 30 large box into 10. Logic here is in the 30 large box, there is 6 second. Okay. So it is also called 6-second rule. So we have done the rate and rhythm. Next, how you can find that the lead placement in the ECG is right or wrong, or it is a case of dextrocardia or not. Okay. So for this, you have to see these leads, means V1 to V6. V1 to V6. In this lead, you can see that the R wave, it is the R wave and it is the S wave. So R becomes large. See the V1, R is small. Then see V2, R is slightly greater. V3 almost same. V4 slightly greater. V3 slightly greater. So R is gradually larger. And see the S. S is gradually smaller. Okay. So this is a indication that the lead placement is correct and it is not a dextrocardia ECG. So now see how a dextrocardia ECG looks like. Here you can see that the R wave is getting smaller. R wave is getting smaller, smaller, smaller. So it is a ECG of dextrocardia. So in the third, you have to see the ECG is a dextrocardia or a wrong lead placement ECG or not. So in the normal ECG, if you go on V1 towards V6, the R becomes large and S becomes small. Okay. Next, see the QRX complex. So in the QRX complex, you have to first see the width of the QRS complex. Means this portion, okay, this portion. In the normal or the narrow QRS complex, the width of QRS complex is 2 to 2.5 small boxes. Okay, here you can see the small boxes is almost 2, okay, or 1.5. So it is a narrow or normal QRS complex. When you can call a wide QRS complex if the width is greater than 3 small boxes, then it is the wide QRS complex. 3 small box means 0.12 second. Okay, so in simple way, if the box is less than 3, then it is called normal or narrow QRS complex. It is when the box is greater than 3, it is called the wide QRS complex. Now see how the QRS complex looks like. Wide QRS complex. Let's see 5, 6, 7. So 7 small boxes, okay, means it is a wide QRS complex. So the cause of wide QRS complex is ventricular hypertrophy or bundle branch block, maybe due to left bundle branch block or right bundle branch block. Now one more thing, narrow and wide QRS complex are two types, okay. One is narrow QRS complex with regular RR interval and irregular RR interval, and also in wide QRS complex there are RR regular interval or irregular RR interval. Okay, the cause of regular RR interval with narrow QRS complex is sinus tachycardia, and irregular RR interval is maybe due to atrial fibrillation or atrial flutter. Okay, and in the wide QRS complex, if the RR interval is regular, then it divides further into two types. Okay, one is monomorphic and other is polymorphic. So wide QRS complex is further divided into monomorphic ventricular tachycardia or polymorphic ventricular tachycardia. Monomorphic ventricular tachycardia. Here the ECG is like there is an additional wave called delta wave. It is seen in the WPW syndrome, means Wolff-Parkinson-White syndrome. So it is seen in WPW syndrome, okay, that delta wave. And if it is polymorphic ventricular tachycardia, their ECG is this type, okay, wide QRS complex, but it is polymorphic QRS complex change, okay. It is seen in the Torsades de Pointes, okay. So this is the QRS complex, the wide and narrow, then the polymorphic and the monomorphic. Okay. Next, in the QRS complex, you have to see it is LBBB or RBBB. Okay. Means left bundle branch block or right bundle branch block. So in the right bundle branch block, one mnemonics is Marrow, and in the left bundle branch block, there is one mnemonics is called William. So what is the mnemonics Marrow and William defines? To diagnose the right bundle branch block or left bundle branch block, you have to see two leads, okay? One is V1 and other is V6. One is V1 and one is V6. Here also V1 and V6. If the V1 QRX complex is like this, okay, and V6 QRX complex is like this, then it is right bundle branch block, okay. And in the opposite side, left bundle branch block, if the V1 is like W and in the V6 the QRS complex is like M, then it is left bundle branch block. Let's see in the ECG. See this X-ray. In this X-ray, you can see that V1 is M type, okay, and see the V6. Here is this type, okay. Here is hazy, but this ECG is like this. So it is W. So V1 M and V6 W means it is what? Yes, marrow means right bundle branch block. Okay. Let's see another X-ray, another ECG. Now see this ECG. Here you can see in the V1. V1, here it is the W type. Okay. And you can see the V6. It is the M type. So W and M means William. Okay. So it is left bundle branch block. Branch block. Okay. So hope you understand the right bundle branch block ECG and left bundle branch block ECG. And now once see that the WPW syndrome and torsus D pointy in the ECG. Now see this ECG. Here you can find a typical delta wave. Here you can find typical delta wave. Okay, delta wave. So means it is a ECG of WPW syndrome. And in this ECG, you can find a typical polymorphic ventricular tachycardia. Means it is a torsus D pointy. Okay. So hope you are able to understand how to diagnose the morphology of QRX complex and how to differentiate between WPW syndrome, torsus D pointy, right bundle branch block and left bundle branch block. Okay. After that, you have to see the axis. Let's see this image. You have to remember this image. Okay. This image. Let's simplify this image. This is the head. This is the right hand. This is the left hand and this is the feet. Okay. We all know there are three bipolar leads. Lead 1, 2 and 3. Lead 1 means the right hand to left hand. Lead 2 means the right hand to feet. Lead 3 is the left hand to feet. Okay. Let's simplify. This is the lead placement and the axis is this means center towards the left hand it is called AVL, center towards the right hand it is called AVR and center towards the feet it is called AVF. So see this image, this is the simplified form of this image. Lead 1, this is the lead 1 and this is the direction of the vector. This is the direction of the lead 3. This is the direction of the lead 2 and this is AVL, AVR and AVF. Okay. And this is put as 0 degree. Okay. Then lead 3, this vector is put in here. This is the 1 plus 120 degree. This is the lead 2. This is plus 60 degree. Okay. And the AVL, AVF and AVR, AVF is plus 90 degree. AVL is minus 30 degree and AVR is minus 150 degree. Okay. So to diagnose the axis, you have to see only 5 leads. What are the leads? These are the leads. Leads 1, 2, 3, AVL and AVF. Okay. And keep in mind that the axis belongs to top 2 longest QRS complex. Okay. Let's see in the ECG. See this ECG. This is 1, 2, 3, AVL and AVF. Now which has highest QRS complex? This is lead 1. It is almost 10 small boxes. Then second highest is 8 small boxes. It is 3 small boxes. Here it is almost 5, 6 small boxes and it is also 3 small boxes. So top 2 are 1 and 2. Means the axis belongs to 1 and 2, between 1 and 2. So place here, this is 1 and this is 2. So the axis belongs to this area. So this is the normal axis. What are the normal axis? The plus 0 degree means 0 degree to 90 degree is the normal axis. Okay. And 0 degree to minus 30 degree it is called the leftward axis, not axis deviation. It is leftward axis. Okay. And the plus 90 degree to 120 degree this is called the rightward axis. Okay. And what are the called right axis deviation and left axis deviation? So minus 30 to minus 90, this area is called left axis deviation and plus 120 to 180 it is called right axis deviation. Okay. This area is called right axis deviation. And this area means the minus 90 to 180, this is called northwest axis. Okay. Now see one more ECG. See this ECG. Here the highest is, so it is lead 2 is 10, AVF is 9, 3 is 8 and other is the small, you all can see. So this belongs to 2 and AVF, means 2 and AVF means this area. So it is also a normal axis. Now see this ECG. Okay, first see in this image 1, it is the 7 leads. Okay, here almost 2 leads, here 9 leads. Okay, 1 2 3, and it is also almost 9 leads, and AVF it is almost 4 leads, 5 leads. Okay, so what are the highest leads? Highest positive is 3 and second highest is the negative, means the axis towards lead 3 and opposite towards AVL. Okay, so let's see, the positive means the vector goes towards the right axis and it is opposite to AVL, because AVL is negative. So this is the positive AVL and this is the opposite side of AVL. That's why the leads is negative. So this ECG belongs to this, means 120 to 150 degree, means it is a right axis deviation ECG. It is a right axis deviation ECG. Okay, clear? Now see this ECG. Here the longest is this. It is almost 13 small boxes and it is almost 12 small boxes. It is the 10 small boxes and here it is almost 9 small boxes. So there is top 2 highest QRS complex is lead 3 and AVA, but it is negative. So the axis belongs opposite to lead 3 and of lead AVF. Let's see, the positive lead 3 is this side and it is negative, so this is the opposite side. This means the minus 60 degree, and the opposite to AVF means minus 90 degree. So the axis belongs to this area, means it is a left axis deviation ECG. So it is left axis deviation ECG. Okay, there are many more techniques to determine the axis, but I use this technique. You can use any one of them according to your comfort. Now see the causes of axis deviation. First, left axis deviation. One is physiological causes and another is pathological causes. In physiological causes there is pregnancy, obesity and ascites, and the pathological causes are left ventricular hypertrophy and left anterior hemiblock. Okay. Now the causes of right axis deviation. It is physiologically seen in tall, thin adult and pathologically seen in right ventricular hypertrophy and right posterior hemiblock or COPD. After that, we see, is there a left ventricular hypertrophy or right ventricular hypertrophy? So to see left ventricular hypertrophy present or not, you have to see the lead V1 or V2, whichever is longer, okay, and plus V6 and V5 and V6, okay. If V1 or V2 plus V5 or V6 is greater than, it is greater. So if greater or equal to 35 mm, then we call is left ventricular hypertrophy. Or another method, if the AVL is greater than 11 mm, then we also call left ventricular hypertrophy. Okay. Okay. So now see in the ECG, what I am telling that V1, see in this ECG, V1 or V2, whichever is longer. Here the V2 is longer. Okay. So we calculate the V2. So it is 23. Small boxes mean 23 mm. Okay. And in this we find that V5 or V6, whichever is longer. Here the V5 is longer. So it is 18 small box means 18 mm. So we calculate here 13, 23 plus 18 means, so 41. Okay. 23 plus 18, so 41 mm. Means it is greater than 35, means here the LVH is present. See another method, that AVL. See the AVL. and see the AVL. In the AVL, the AR or S, whichever is longer, the here the S is longer and it is 5, 10, means greater than 11. Okay, greater than 11 mm. So it's a left ventricular hypertrophy. Now the right ventricular hypertrophy. It is simple that we see the V1. Okay, in V1, if the R is greater than S, then it is right ventricular hypertrophy. See in this ECG, we see the V1. In the V1, R wave means positive wave. It is the QRS form, QRS. Okay, it is Q, it is R, it is S. So if the R wave is greater than the S wave in V1, then it is called, then it is a right ventricular hypertrophy. So in here it is right ventricular hypertrophy. This ECG also there is right ventricular hypertrophy as well as left ventricular hypertrophy. So what are the cause of left ventricular hypertrophy? It is AR means aortic regurgitation, MR means mitral regurgitation, then ischemic heart disease, and anemia and thyrotoxicosis like hyperkinetic circulatory state. Okay, and what are the cause of right ventricular hypertrophy is MS and pulmonary hypertension. One more thing, see in this ECG that here is a ST depression. Okay, so that LVH with ST depression means this is a case of chronic hypertension. Okay, after that we see the P wave and PR interval. At first see what is the PR interval and PR segment. This is the P wave and this is the QRS complex. So end of the P wave and beginning of the QRS complex, it is called PR segment. Okay, PR segment, and starting of the P wave and starting of the QRS complex, it is called PR interval. Normally P wave is like this, smooth and everted, but it may be notched P. Means if the height of the P wave is greater than 2.5 small boxes, it is called notched P or pointed P or P pulmonally. Okay. So what is the cause? Cause is the right atrial enlargement seen in the COPD. Okay. Another P wave is the notched P, like this notch. See the notch. What is the cause of notched P? The right atrial enlargement seen in MS, MR and hypertension. Okay. Next is the biphasic P. Is the positive and then negative. So this is the biphasic P. What is the cause? The interference of atrial conduction. Means it is the conductive defect in the Bachmann's bundle. Okay. Then the everted P. Everted P is seen in dextrocardia patient. And then absent P or fluttered P wave. It is seen in atrial fibrillation or flutter. Let's see some ECG. See in this ECG that the P is pointed. So it is pointed P. Okay. Means P pulmonally. Now see in this ECG, the P wave is inverted. So this is inverted P. We all see in the lead 2. See, this is notched P. Okay. M-shape P. Now see, this is biphasic P. And now see this ECG. There is no significant P wave. So it is a case of atrial fibrillation or atrial flutter. So this is all about P wave. Now see the PR interval. It is very important. So PR interval is two types. One is short PR interval and long PR interval. Short PR interval cause is tachycardia, long PR interval cause is heart block. Okay, so heart block is three types. One is first degree heart block, second degree heart block and third degree heart block. Okay, what is first degree heart block? Means here the PR interval is greater than 5 small boxes and it is constant beat to beat. Okay, let's see in the ECG. See in this ECG, it is the beginning of the P wave and it is the PR interval. Okay, so this is 6 means greater than 5. Here also almost 6 greater than 5 and it is also greater than 5 and 6 and it is in regular interval. So beats it is constant and it is greater than 5 PR interval. So it is a first degree heart block. Now the second degree heart block. So second degree heart block is two types. One is MOBIS 1 and one is MOBIS 2. So what is MOBIS 1? Here the PR interval is gradually increasing followed by a drop beat of QRX. Okay, let's see this ECG. It is the P wave, this PR interval. Okay, then it is more gradually increasing the PR interval, and then there is no QRS complex. Okay, there is no QRS complex. So the length is gradually increasing and followed by a drop of QRS complex. It is a second degree heart block, MOBIS type 1. Okay, then the type 2. Here the PR interval is same but followed by a drop of QRS complex. P wave with no QRS complex, like this. Okay, let's see. P wave interval is same, PQ interval same, sorry, PR interval same, PR interval same, then there is no QRS complex. So if the PR interval is same but drop of QRS complex, then it is MOBIS type 2. Okay, so these two is second degree heart block. Then third degree heart block. Now see the third degree heart block. In the third degree heart block, there is no relation between the P wave and QRS complex. Means P wave beats its own beat and QRS complex beats its own beat. Okay, let's see. Here the P wave, there is interval is far better, more longer, then shorter, then more shorter, more shorter. But there is no relation between P wave and QRS complex. P wave beats in its rhythm and QRS complex beats in its rhythm. Okay, so this is called third degree heart block. Now the most important is ST segment, means ST elevation or ST depression. At first, see about the ST depression. First see this image. This is the normal ECG and it is the baseline. Okay, you have to prefer elevation or depression from this point. Okay, so here there is no ST elevation. In this ECG, it is the baseline and it is the ST elevation, and here the ST depression. Okay. First we see about the ST depression. So causes of ST depression is non-ST elevation MI, digoxin drugs effect, hypokalemia or bundle branch block. These are the cause of ST depression. Okay. Now see the ST elevation. ST elevation main cause is ischemia. Okay, myocardial ischemia seen in ST elevation MI, and others like pulmonary embolism, cerebrovascular accident, hypothermia and hypertrophic cardiomyopathy, then cardiac aneurysm. Okay, these are the other cause where you can see the ST elevation. Now see how to diagnose MI. MI, okay, means myocardial infarction. How to see the myocardial infarction and which valve is involved? Very easy. Okay, you have to understand just this data. You have to remember just this. At first, see in the lead V1. Okay. V1, if ST elevation seen in the V1 means the septal wall is affected. Okay. If the leads ST elevation is seen in V2 to V4 means V2, V3, V4, then it indicates the anterior wall MI. If the ST elevation seen in V5, V6, then it indicates the lateral wall MI. If the ST elevation is seen in 1 and AVL, then it is high lateral wall MI. And if the 2, 3 and AVF ST elevation is seen, then it is inferior wall MI. Okay. And another thing to remember, when you can call it is a significant ST elevation. If the age is less than 40 years, then the greater than 2.5 small boxes is called significant ST elevation. And if the age is greater than 40 years, then greater than 2 small boxes is called significant ST elevation. And in case of female, it is 1.5 small boxes. Now see this ECG. In this ECG, 1 is normal, 2, 2, here is elevation. Okay. 3, here is elevation. No other such elevation. 1, that AVF is also elevated. Means 2, 3 and AVF is elevated. Means it is a inferior wall MI. Okay, 2, 3 and AVF. Means it is inferior wall MI. Okay, you have to just remember these 5 points. Then you can tell all the MIs. Next, see this ECG. Here 1 is not elevated, 2 is normal. Then see the V1 is elevated. Okay, V2 is elevated, V3 is elevated. So V1, V2, V3. V1 means septal wall is affected. V2, V3 means anterior wall is affected. So it is anterior septal wall MI. So it is anterior septal wall MI. Okay. Now see this ECG. Here 1 is elevated. Okay. Then AVL is elevated. Okay. So 1 is elevated, AVL is elevated. Means it is high lateral wall MI. Okay. Now see this ECG. Here the lead 1 is affected, means ST elevation is seen, and as well as AVL is seen. AVL means that it is high lateral wall MI. Then see the V2, V3 and V4. Here it is also ST elevation, means the anterior wall is affected. Okay. So and here see the V5 and V6. It is also elevated, means lateral wall is also affected. Okay. So means it is MI and it is anterolateral wall MI, affecting the anterior wall, high lateral wall and lateral wall. Okay. So all MI is done here. Let's see how posterior wall MI is presented in the ECG. See this ECG. Here V1 is depressed, V1 is depressed, V2 is also depressed, V3 is also depressed, V4 is also depressed, V5 is also depressed, but V6 is not so much depressed. Okay. So it is the reciprocal changes, means all leads, as all leads are in the anterior wall, means if the changes, if the MI affecting the posterior wall, all the anterior wall leads shows the reciprocal changes, means ST depression. Okay. As V6 is most lateral, so V6 is not seen the reciprocal changes properly, but from the V1 to V5, V5 is also a lateral wall, but V1 to V4 you can see clearly the reciprocal changes of ST depression. Okay, it is a clear cut sign of posterior wall MI. So where you can see the ST elevation, if the lead extend to the back, okay, means the extended leads, means V7 and V8, okay, V7 and V8 which is put in the back of the patient, then you can see the ST elevation. Okay. So this is all about the MIs. Now few more small things, that the T wave and the QT interval. So this is T wave and this is the QT interval. Okay, beginning of the Q and end of the T, QT interval. Okay, so T is normally smooth, but T may be tall T, means this type. Okay, means this type, the steep T, tall T. If the T is greater than 2/3 of QRS compass, then it is called tall T. So what are the cause of tall T? That is hyperkalemia or hyperacute MI. Okay, this steeple T is classically seen in the hyperkalemia. Okay, another type of T wave is inverted T wave, like this. Inverted, it is called inverted T wave. It is seen in the cardiomyopathies, in raised intracranial pressures, bundle branch block. Now the QT prolongation, if it is greater than 440, means 440 millisecond, means 11 small boxes, then it is called prolonged QT interval. Okay, cause is hypokalemia, raised intracranial pressure and hypothermia. Okay, and if the QT is shorter, means the less than 350 millisecond, then it is called short QT interval, and cause is the hypercalcemia and digoxin toxicity or digoxin side effect. And now the last, U wave. So now U wave. U wave is not seen normally in the ECG, but prominent U wave is seen in few cases. The hypokalemia, hypercalcemia, thyrotoxicosis, etc. Okay. and it looks like this. Okay, this is P, this is T, and this is U. Okay, see in the ECG. Now see this. This is the U wave. Okay, this is the U wave. So it is a typical finding of hypokalemia. Then you can see this type of U wave also, inverted U wave. The cause of inverted U wave, it is seen also in MI or left ventricular or volume overload. Okay. Okay. So just quick recap how to diagnose the ECG. At first, see the rate, then the rhythm, then leads are placed in right way in the ECG or not, then characteristics of QRX complex, then axis, then there is any left ventricular hypertrophy, right ventricular hypertrophy or not. After that, the P wave and PR interval, then the ST segment. After that, the P wave and QT interval, and then U wave. Here, the most important things are, one is the QRS complex, then the axis, then P wave and PR interval, and then the ST segment. Okay, these four are the most important. So that's the end of the video. And now go to the playlist of ECG and practice ECG in 1 minute.